Yes, hello everyone. My name is Elil and I welcome you today to this very special patient summit, Bouncing Forward, Getting Active After Surgery, jointly organized by OAS and ConvaTec. We will be taking questions at the end, so please put them in the Q&A section by clicking on the icon at the bottom of your Zoom screen, and we'll answer them during the last 10 minutes. Last month, we celebrated World Ostomy Day on 2nd October. This is held every 3 years around the world, and this is our 10th year with the theme, Ostomates' Rights are Human Rights, Anytime and Anywhere. So the Ostomy and Continent Diversion Patient Bill of Rights produced by the United Ostomy Associations of America has highlighted needs, expectations, and recommendations for pre-, during, and post-surgery care for a person undergoing ostomy or continent diversion surgery in order to achieve a desirable quality of life. And that's what we are going to be talking about today in this session in relation to support and resources available as we go through our surgery and then our recovery and our life living with an ostomy, and how the community can continue to do better to support ostomates in their recovery journey. Right, so today we are bringing together three very special people in our ostomy community, Ms. Joan Heng, Dr. Dean Koh, and Ms. Hui Chen. Right, so let me just tell you a bit about myself. I'm a double cancer survivor and I'm actively involved in social work. The main areas of my volunteer work are SingHealth, Singapore General Hospital, Changi General Hospital, and the Singapore Cancer Society. I'm also president of the Ostomy Association of Singapore and co-chair of the SingHealth Patient Advocacy Network. And then we have Joan, who is our first panelist. Joan is the vice president of the Ostomy Association of Singapore, and she will share more about herself and the inspirational journey during the panel discussion. Dr. Dean is a senior consultant, general and colorectal surgeon with over 20 years of experience. Dr. Dean completed his training and fellowship in the UK and US. He is a past president of the Society of Colorectal Surgeons in Singapore. He is passionate about treating colorectal cancer and other colorectal conditions using minimally invasive techniques and robotic-assisted laparoscopic surgeries. Aside from his clinical practice, he is currently an adjunct associate professor in the NUS Department of Surgery and has authored multiple peer-reviewed journals on colon and colorectal conditions. And last but not least, we have Ms. Hui Chen, who is Deputy Head of Department and Senior Physiotherapist from the Singapore Cancer Society Rehabilitation Center. Currently, she leads the rehab team in developing evidence-based oncology rehabilitation programs. She hopes that through the various ongoing studies conducted in Singapore Cancer Society Rehab Center, we can further validate the effectiveness of engaging in safe exercise through the entire cancer continuum, eventually contributing to the basis of future recommendations of rehab practices in Singapore. So I think I've said enough. So let's start the discussion. Let's first start with Joan, right? I know you have been through a lot. Could you share your story on how you got to have an ostomy?
Okay. Hello, everybody. So I became an ostomate only in August 2020 due to some complications from my cancer treatment. I had fistula in my cancer treatment when I went through the, I was diagnosed with ovarian cancer. So I went through chemo and I have fistula, which leads me to having to wear the stoma bag last year. And if you look at me now, I'm in a beanie because I'm back to chemo again. My chemo came back. I had a relapse early this year. So I'm currently under treatment again for chemo. And yeah, so that's me and my cancer journey. I joined OAS in 2020 when I was diagnosed with, when I had to wear this stoma bag. And maybe later we'll talk a bit about that journey as well. Thanks, Elliot.
Thanks, Joan. As for me, right, I had to have my stoma created because of rectal cancer. and the tumor was too close to the anus, so the doctors had no choice but to remove the tumor and the area surrounding it, and ended up with a permanent stoma. So my surgeon at that point, when he told me about the stoma creation, right, was quite confident about the treatment option, and I could tell that he knew his stuff. So agreed to let him operate on me 3 weeks after that, right? Dr. Dean, can you maybe tell us about how you got to be a specialist colorectal surgeon and what drew you to this area of specialty?
Elio, it's a difficult question to answer, because if you ask most of us surgeons, not everyone would have that clear a picture right from the beginning of training. Most of us just try to survive the intensity of being a surgical trainee. So all of us went through general surgery training, and then of course during general surgery you rotate through the different subspecialties. And it was not an epiphany for me, meaning that it was not like one day I woke up and said I wanted to be a colorectal surgeon. I think it was when we rotated through, I found that I took a great liking to it, and it was almost like fish to water for me. I understood the principles manipulating the bowel. And then, of course, the opportunities that arose after I'd finished my general surgery training, where the positions for colorectal residency in the US opened up. And so I matched after interviewing there, and I spent my time in Michigan training in the formal colorectal surgical program in the US. And so that's how I ended up doing colorectal surgery.
Very interesting. So now turning to Hui Chen, right? You see many patients with different cancer types in your rehab center. Can you maybe tell us about your work in the Singapore Cancer Society Rehab Center and how you've been drawn to support people with stomas?
Hello everyone, my pleasure to be here. So over at Singapore Cancer Society Rehabilitation Center, so my lovely team and myself work largely with cancer survivors after they have completed their major cancer treatment. And that may include surgical removal of some part of the body tissues, radiotherapy, and chemotherapy, so on and so forth. So very often, colorectal cancer survivors faces a myriad of physical and psychosocial challenges despite improvements in survival rates. And these lingering barriers eventually then lead to poorer quality of life and physical outcome. So as a physiotherapy myself, I have the privilege to journey with patients with permanent stoma bags, and most of them do report some of the practical challenges, such as difficulty in returning to their usual routine and hobby. So for example, brisk walking to nearby coffee shops to meet their friends for coffee, or simply unable to cope with the care of the new stoma bag because they're worried about the risk of stoma bag leakages while they're exercising, for example. So I do hope through more advocacy work, we encourage more healthcare professionals to understand what are actually available in the Singapore community. So for example, OAS or ConvaTec and even Singapore Cancer Society in supporting them to reach a more informed decisions about their care moving ahead.
Nice, thanks, Richard. So Joan, coming back to you, right? If you think back to the first few months after your surgery, tell us about the support and the resources or lack of them, right, that you received.
Okay, actually, even after the surgery, I have not heard of stoma. I don't know what is stoma, and when my doctor say, due to the fistula, I need to wear a stoma bag, I have no idea at all what it is all about. And so I have zero knowledge. And when he asked me to do it, I just say, okay, go ahead, as long as, you can help me with my bowels. And so after the surgery, the nurses taught me how to change the bag. They also gave me a list of food that I should not eat. But that's it. And I have no one to turn to. So the great help came when I met Elio at an interview on cancer. And I contacted him to ask him questions. So he introduced me to OAS, and I joined as a member. In the past 1 year that I've been a member, I've learned a lot from all the various webinars that I've attended and the people I've met. So really, I don't know what my life would have been if I've not met Elil and, you know, attended all these very insightful webinars. Yeah.
So I'm really glad that, you know, you managed to get the support that you needed early on in your journey, Joan. And I was not so fortunate for an entire year when after I was diagnosed, right, I was relying on the internet for information and support, and actually joined an online support group in UK. But they were absolutely brilliant, and they put together a really comprehensive resource package and sent it to me via snail mail, and at no cost to me whatsoever, right? So they gave me the assurance that there was help out there, and it was just a matter of reaching out, right? So, Dr. Dean, can you share some of the experiences you've had when you had to tell a patient that they were going to need an ostomy, and what their response was like?
I'm pretty sure that no surgeon will tell you that they have had any patient who were joyful when they hear that they need a stoma, be it temporary or permanent. It's the usual despair, disbelief, denial, the process. Some even downright refusal. Say, nope, no way. I'd rather, you know, not have anything done than to live with a stoma. And those are the usual responses that we get. You know, it's very interesting that technology has improved so significantly that fortunately for everyone, you know, the stoma rates have dropped with the advancement in technology. And when I say advancement in technology, I am specifically referring to more towards the patients with rectal cancer, like what you said for yourself, Elil, because I would say 30 years ago, about most patients with rectal cancer would have to live with a stoma. But now with the equipment and technology like robotic surgery, staples that we can use now, we are able to actually preserve the anus in quite a large number of patients. And that's where we get a lot of our consults from, because patients come and say, look, you know, I've been told I need a permanent stoma. Is it possible for you to save my anus? And don't forget, the advancement in chemoradiation is incredible. Now the response rates for tumors, rectal cancers, when they go for chemoradiation, you're able to shrink these tumors. So in the past, prior to chemoradiation, we are not able to save it because the tumor is too big, but because it shrinks to a certain size, we are able to do that, right? So I think that the awareness that has been growing, especially with the OAS and the different societies, I think the support groups are absolutely essential. If you look at what happens in the United States, there's extremely strong support groups. And I think support groups are as important, if not more important, than the surgeon, because we only see the patient once, twice in a period of time. But on a day-to-day basis, patients need that support. They need to know who to turn to. You know, oh, this bag, there's something wrong, there's a leak, what should I do? So I think the OAS and the ConvaTec and all the ancillary societies are extremely useful. Yeah.
Thanks, Dr. Lee. So coming back to the rehab side, Hui Chen, what are the support resources available at SCS Rehab Center?
So we have a variety of cancer rehab programs and services to help osteomates to minimize cancer treatment side effect. So say, for instance, to deal with muscle weakness and lower limb numbness, as a result of certain chemotherapy drugs, our physiotherapists partner with ConvaTec to create a more structured exercise program, specifically for osteomates to recondition their body back to normalcy as much as possible in order to function independently, because ultimately we're looking at for them to return back to their usual morbid. So for example, I love to go to a coffee shop to meet my friend for coffee, for example. So in addition to physical rehabilitations, we also provide complimentary dietary consultation run by our own dietitian to encourage osteomates to adopt a healthy, balanced diet, which help in promoting more regular bowel movement to reduce likelihood of constipation. And I think the other spectrum is to really nurture resilience and encourage cancer survivors to take charge of their own health. So SES has our own dedicated pool of psychosocial team comprising of social worker, sexologists, and art therapists that helps to provide further useful self-care strategies and interventions to manage some of the osteomate fears and insecurity during the course of rehabilitations.
Right. Thanks, Richard. And then now, right, when we look at the other side of all that, thinking about our surgeries and what happened immediately afterwards in those first weeks or months, was there something that was missing that you would, if you look back, say, right, this would have really helped me at that point? What was missing from your care right at the beginning of your journey, Joel?
For me, I'm a very outdoor person. And, I like to exercise, but that initial period, really, I didn't dare to do anything because I was just afraid that my bags will leak. And also initially, no one told me about this parastoma hernia. And I only found out at one of the webinars that I attended. So thankfully, I haven't developed one, but I'm really, keen to know more about this parastoma hernia. What are the types of exercises that I can do so that so I can stay active, but at the same time, I won't develop this parastoma hernia.
Right. So, Dr. Dean, if you could talk a little bit about parostomal hernias, if Joan had been your patient, what advice would she have gotten from you about parostomal hernias, and maybe share the importance of rehab and exercise as part of the recovery journey, especially for hernia prevention? And what are the implications of reduced physical activity? And why does having a hernia affect activity levels? So there's quite a few questions there. So yeah, I hope you can shed some light on that.
I'll try to do what I can. I think, Joan, it's understandable that once you hear of complications from stoma, you get very concerned. You need to know that there are many potential complications from a stoma, not necessarily just parostomal hernia. In fact, the commonest complication from a stoma is actually not parostomal hernia. So you'll be relieved to know that. I think the concept of a parostomal hernia is like any hernia, meaning if you know patients have groin hernias, they have incisional hernias. The basic principle of hernia formation is due to weakness in the tissue, meaning in the muscle. Okay, so a parostomal hernia just essentially means that the opening that was created for the stoma to come out, or the intestine to come out, has enlarged. It's gotten too big. It's gotten wider than the stoma. And as a result, the contents from the abdomen actually protrudes out. I will share this screen so that you have a better idea. Okay, Elil, is that okay?
Yes, please go ahead, doctor.
Okay, so I'm going to show you this. Can you all see this?
Yes, we can.
Okay, you can see my cursor. So this is your stoma. This is your stoma that's coming out. This is your skin. So you can see this is the opening in the muscle. The opening in the muscle has gotten too wide because of laxity or weakening of the muscle, so that the other loops of the small intestine protrudes out into this under the skin. So you get a hernia here. That's just one type of hernia. This is another type, you see. So the stoma is out, but because the gap is wider than the diameter of the stoma, the other loops of intestine protrudes out, okay? And then another example would be not the other intestines, but the colon or the intestine itself protrudes out and forms a hernia. So these are the common causes of a hernia, okay? I think, John, so like any hernia, strengthening of the muscle will prevent that. But bear in mind, it's not just the muscle alone. The creation of the stoma, the causes of peristomal hernia are multifactorial. One of the most critical is the surgical technique. So that's why it's very important that for us surgeons, that we make sure that we create the stoma in a manner that is best suited for the patient. Of course, you have to bear in mind that the nutritional status of the patient, whether you have other conditions like diabetes, what is the underlying condition? If you have infection underlying, if you have wound infection, all these will increase the risk of peristomal hernia formation. So I think rightly so, you are concerned about the incidence of leak and so on, but that we always encourage our patients, don't let that restrict your activity. You know, engage all the resources that we have available to help to minimize that risk of leak. And I think leakage is the commonest complication and the most feared by most patients, and it's the one that restricts the quality of life of most ostomates. So I think once we get over that and we can address the leak, they are able to regain their activities, their normal activities. And then of course, when you have your normal activities, your muscles don't weaken, that will help. Yeah.
Yeah, that's really good advice, and thanks for telling us more about how hernias are formed. And now going back to Hui-Chen, right?
Can I ask?
Yes, yeah.
Yeah. So is it advisable for us to wear like binders and things like that to prevent the hernia from developing?
That's okay. It's not medically proven that binders will reduce the incidence of hernias, be it peristomal hernias or incisional hernias. Binders give you a support. The problem with patients with a stoma is, in order for a binder to work even to a certain extent, it must be tight enough to support and push the contents back in, right? But don't forget, for ostomates, you have the stoma that's protruding out. So if you have something tight that binds, you are also compressing the stoma back. So no, you don't have to use a binder at all. You don't have to worry about it. I would just say be as active as you can be in your normal sense. You don't have to go overboard and do crunches and try to build up your abdominals. But like I said, it's multifactorial. It's not just one factor that you can prevent. Okay.
Right. Thanks, Dr. Lee. Now I would like to shift the attention back to the rehab part and to Hui-Chen. Hui-Chen, could you share some guidelines on safe moving, when and how, and getting back to an active life after surgery?
The key fundamental factor for all osteomates is about creating a safe space for them to access to appropriate exercise facilities under guidance of rehabilitation specialists for staff. So it's very common to hear many survivors worry about the safety aspect of exercising after surgery. And usually they're unsure about the amount of weights they should carry, and like Joan, worry about the risk of peristomal hernia. So to rectify such a gap, ConvaTec and Singapore Cancer Society Rehab Center, we collaborated to launch a Knee Plus recovery program, which provide advice and support about the importance of movements and physical activity after stoma surgery. So the program is it's aiming at to aid in terms of recovery and also to improve long-term outcome, specifically a lot of muscle conditioning. And during the consultation, osteomate will be taught on how to exercise safely and regularly. I think that's key. On using body weights or easily accessible household items such as chairs and water cans, etc., to help them during their muscle reconditioning. So depending on the stages of cancer recovery, osteomate who have completed cancer treatment as compared to another osteomate that's undergoing chemotherapy, the exercise intensity differs accordingly. So all in all, exercise is actually safe for all osteomates throughout the course of cancer recovery. However, it needs to be tailored to individual based on their individual cancer profile and their cancer treatment journey.
Right. So for me, right, again, I wish I'd been told the risk of developing a peristomal hernia, and maybe some kind of warning with precautionary measures, maybe, that I could take to prevent it. So I only learned about it after I developed peristomal hernia myself.
Okay.
Right. So, but then again, we try to advise patients to be more cautious. Of course, Dr. Dean shared about, the support governments. I think that is another conversation in itself, which we can take up in another forum. So, what was the most challenging thing for you, Joan, after your surgery?
I have many challenges. So, yeah, let me just go through. So first of all, it's managing my stoma. So initially when I clean it too hard, the stoma starts to bleed. So that is also something that I was very worried about. Every time I see blood here and there. Then my stoma is on the right side. So my stool is very watery. Even I drink a cup of water or a cup of milk, it's like it goes directly to the back. So I'm not sure, is the watery stool due to diet, or is it because it's on the right side? I just don't understand, So I'm quite afraid of drinking water actually, because everything is like goes to the back and it becomes very heavy because it's so watery. Then the other question I have actually is there a difference between the stoma on the right or the left? Mine is on the right. And one other challenge is that I noticed that the stoma has two holes, and one hole is like permanently stuck with some very glue-like substance. If I try to clean it, it bleeds. So that's something I'm not sure what should I do with that hole. The other one, of course, it disposes all the waste and I can clean that. So I'd like to know, why do they construct the stoma with two holes? And one final challenge I have is really about reversal of the stoma. I've heard a lot of horror story about reversal. I like to check with Dr. Koh, is that, something as a patient I should think about, and what is the pros and cons of this reversal? Yeah, those are my challenges. It's quite a few. Yeah.
Shall I proceed, Elu? Yeah.
Yes, please.
Very, very honest sharing. I'm very glad that you brought these up. I think first, the simple thing of bleeding. Don't worry about bleeding. Basically a stoma, the part of the tissue that you see at your stoma is meant to be inside. That's the inner part of your bowel, right? So we call that the mucosa. So a little bit of trauma, it can bleed, but to stop it, unless you're on blood thinners, you can easily stop it by pressure. Just apply pressure. Pressure with a gauze or with tissue, it will stop. So don't worry about bleeding. It's not going to cause any permanent damage. Yeah. Now, whether the stoma is on the right or on the left is usually not indicative of the type of stools. It depends on the surgical condition and situation, and that depicts where we site the stoma. Of course, typically, but not always, on the right lower side, it is what we call an ileostomy, meaning it is a stoma created from your small intestine, okay? As opposed to a colostomy, which is a stoma created from your colon. So if you imagine, if it's a colostomy, meaning a stoma created from your colon, your stools will be like your normal stools. You know, there will be form, they will have that same odor, that same smell, and the quantity will be less. But if your stoma was created from the small intestines, like an ileostomy, which I suspect yours is, then it's small intestinal juices. So it will always be more towards the watery side, simply because it has not reached the colon. And the colon is the organ that's responsible for absorbing the bulk of the water to create stools. So because yours is a small bowel stoma, you don't have the benefit of the colon absorbing the water content. So it becomes watery most of the time. So please don't let the watery content lead you to drink less water. It makes no difference because it's small intestinal juice. So whatever it is, it will be watery. There are medications that we do prescribe to help to slow that down, to reduce the liquid state of the ileostomy output. So I think if you speak to your surgeon, they will be able to advise you on what you can take. There are medications that we do prescribe, and most of my patients, they actually know how to manage them on their own. And this is specific for ileostomies. For patients with colostomies, they usually don't have that, that problem at all. Yeah, okay. Now, why are there two holes, right?
Yeah.
Okay. I am going to share this with you so that you have an idea what we're talking about. Hold on. I hope to be able to. Can you see that?
Not yet.
Not yet, is it? Okay. I'm hoping to share that with you, but somehow it's not coming out. Give me a minute, huh?
Sure. Take your time. So in the meantime, we've already have some questions that we received previously, and we have a new question. We address that at the end of the session.
Okay, I got it.
Yeah, go ahead, Dr. Go.
Okay. So, Joan, what you have is an ileostomy. So an ileostomy is this. If you can see, that is your small intestine. Yes? Okay, you can see my cursor?
Yes.
So what your surgeon has done is your surgeon has pulled this U-shaped loop of small intestine out through your stoma opening here. Can you see that? Okay. And then what he did was this. He made a cut here and then he flipped it open like that. So that's why your stoma has two openings, because you're basically opened up your ileostomy this way. You make that cut, you flip this edge over, there you go. So your intestine should be going this way, right? From here to here. So therefore, you will find that there will be one opening where all the waste comes out. Yes?
Yeah.
The other opening doesn't do much, because the other opening, if you put your finger in, it will go towards your colon. So your stool has been diverted from your colon. Nothing goes through your colon now. Everything comes out from this opening. Now, if you see mucus, which is what you're describing, appearing in this lumen, you don't have to clean it. Leave it alone. It's benign. It's not going to cause any problems, because the lining of the intestine naturally produces mucus. It's to lubricate the lining. So the content comes out from here, it's collected in your bag. Here, a little bit of mucus. Don't worry about it. You don't have to diligently go and try to remove it.
Okay.
Okay, so that's the loop, and that's why there are two holes. Okay, does that answer your question?
Yes, it does. Thank you.
Great.
So, thanks, Dr. Koh. I think.
Wait, I have one more challenge, which was the reversal.
Oh, okay.
Oh, yes. Now,
Yes.
if yours is a ileostomy reversal, okay, it's very different from a colostomy reversal. So an ileostomy reversal is technically easier and is less fraught with complications, because basically you saw that diagram that I drew for you, right? Or I showed you. Basically, for your reversal, it's just a matter of disconnecting the thing from the skin and just recreating what was artificially created. So that's easy. For colostomy, it's a little bit more tricky because the colostomy is usually brought out as one end. Okay, the other end is still somewhere inside. So therefore, to reverse it, we need to take the end that's coming out through the skin, disconnect it, go back in and search for the other end downstream, and then hook it back up. So that one is technically more challenging, and usually those are the ones that you read about when it's when you have a lot of issues, problems, and so on. So that's why for colorectal surgeons, we try very hard not to perform an end colostomy. Actually, an end colostomy is what Elil has. You know, but just imagine if you were able to still have the lower part, you have to go back in and hook it back to the lower part. And that involves you going back, involves us going back into the abdomen, which is a lot more challenging than for you, John.
Okay.
Okay?
Yeah, thank you.
And then, Dr. Koh, I must say, those were some of the clearest answers I've gotten about reversal and about the two holes, right? So thank you so much for explaining it so that we could understand.
Well,
Right, so I want to go to Hui-Chen now. How about your patients, Hui-Chen? What do they say about exercising with the stoma and all?
I think generally when a patient comes to me, they do not have a lot of stoma concern because thanks to our highly skilled nurses in the hospital, we spend a lot of time with Joan, for example, to educate, empowering them how to navigate the stoma bag. So I guess the other spectrum of challenges would be in terms of financial, because I think generally my patient will share with me they will have some issues selecting affordable and well-fitted, comfortable stoma pouch. And that generally heighten the level of distress and financial responsibility. So I'm glad within the Singapore community, there's a really pool of organizations like ConvaTec, for example, that provide a comprehensive range of inexpensive stoma products.
Right. So for me, right, my worst fear was actually how I would get back to work because we need to put food on the table, we need to pay the installment for the house, you know, earn money to survive, and also to carry on the activities that I was doing before. So with the stoma, will I still be able to do all that? That was my biggest fear, right? And as for the other challenges, well, I saw this article in the paper showing one of our very senior patient ambassadors. For those of you who know him, is Mr. Teo, right? He was reaching his 70s at that time and he had a permanent stoma, right? Like mine, and he was playing basketball and badminton, he was swimming and running. I mean, oh my God, right? I read the article and I thought if he could do it, then I can too. I was much younger then because I was only 52. And so I said, okay, this is it. And I'm going to do this and I haven't looked back since, right? So, and nowadays, right, as Hui-Chen also mentioned, the ready availability of the right ostomy appliances was very important. Something that would give me the confidence to do all the activities that I wanted to do and also not be too cumbersome to prepare and use. So like for me, the perfect solution was those moldable wafers that you have. Now, I didn't even have to cut the hole in it or anything. I just had to stretch it, put it on, and then put on the bag, and that was it. And because it sort of forms around and hugs the stoma, there was very good fit and no leakage at all. So these things really help when you want to maintain an active lifestyle, right? And so before we go to the questions, right, just in as few words as possible, I mean, this question is going to be posed to all the panelists. Just in a few words, what would be your top piece of advice that you would give to the osteomate community? Maybe we can start with Joan.
Okay. Actually, for me, support is very important. And where can I find information? So those are important for me. And so joining OAS, not selling koyok, but joining OAS was really a very wise choice for me, because over this 1 year, I actually learned a lot from all the webinars and the people that I've met. Like what Ilil mentioned, like people like Mr. Teo really gave me a lot of encouragement. They have been wearing the stoma bag for 20, 30 years and they're not complaining. So it has become like part of their life. They've gotten used to it. So I always tell myself, if they can do it, I can also do it. So that's how I have, been going through this stage of wearing the stoma. And I always feel that I don't have to suffer this alone. There's many people out there that can help me. So yeah, that's my advice. Join a support group or OAS especially, and attend webinars, be more informed. I think that will get you out of a lot of fear.
That's really very good advice, Joan. Dr. Dean?
I think I only have just one sentence for them. Having a stoma is not the end of the world. Okay, you have like yourself, Elil. I mean, if I look at you like that, nobody knows, right? Even Joan, nobody will know. So it's not a stigma. It's not a stigma whatsoever. It's you've heard success stories, and then I have several patients who I have patients who do swimming, like you've mentioned. They play sports, active sports, right? And I even have a patient who's supposed to have a temporary stoma, who still has the temporary stoma. He's so happy with it and he's managing it so well. He doesn't want it reversed. So I think it can be, you can have a normal life, but the caveat is that your surgeon must also be able, and your support societies must be able to determine whether it is just managing the stoma, or is there something fundamentally problematic with the stoma that needs to be addressed. Because sometimes, don't forget, we are not perfect. I wouldn't be able to create a perfect stoma 100% of the time. So sometimes there are issues, technical issues, that we have to correct first, and then that will allow the osteomate to have as good a quality of life as possible. So an example would be your peristomal hernia. I mean, if the peristomal hernia is such that it's causing the device to not fit properly and result in leak, then we'll have to have a discussion to see whether we need to fix that so that you then can have a proper life. Yeah. So yeah, I think that's it. Be encouraged. That's all I can say.
Right. That's great advice as well. Hui Chen?
So for me, I would like to encourage everybody that exercise is medicine. So if you are physically fit, mentally well, you will live a healthier and happier life. So take the first step to reach out, to make informed decision. And I believe you're all here for it.
Thank you very much. So in summary, right, I mean, we have really great snippets of advice from our panelists, and there's help out there, right? Reach out. You don't have to walk this journey alone. You can still lead a full active life with a stoma. Having said that, You don't have to climb mountains or cross deserts to prove anything to anyone. Take all the time you need to come to terms with the disease and your condition. Then when you are ready, you can start your rehabilitation process. Get active again and enjoy life with your loved ones and friends, right? So now we shall take some of the questions. Prior to today's session, we already had some questions that came through registration. And maybe I'll take the first one first. Is it okay to carry weights 9 months post-surgery? Dr. Dean first, then maybe Hui Chen.
I think with we have a general advice for any patient undergoing major abdominal surgery. And my advice to patients would be 6 weeks, no heavy lifting. Okay, because you need the tissues to heal and scar down. But if you tell me you're 9 months out from major surgery, then most of the tissues would have scarred down and provided they're healing well, then yes, you should be able to start to ramp up your weight lifting. Of course, it also depends on how heavy your weights you are lifting. I mean, if you're doing bicep curls, a little bit of bench presses, that's fine. But of course, if you're going to do those hardcore squats with the I don't know how many kilograms over your head, that's going to be a bit trickier. Yeah.
Pichen, maybe before you come on, I can add a couple of other questions that had come through our chat today. In addition to the earlier question, what kind of exercises to do after a SOMAS surgery? Yeah. Maybe you can address that, whether, first of all, 9 months post-surgery, is it okay? And also what kind of exercises you can do?
Yeah, so generally, we're looking at the tissue healing, as mentioned. So I think we're looking at not injuring the tissue, allowing sufficient time for the tissue to heal, even before you put on weights to that. So I think the key is about gradual starting, low intensity. So you may want just to beef up your aerobic capacity. For example, your brisk walking, your diaphragmatic breathing, to get those muscles that has been switched off for a long time to start slowly to be activated. So we do not want to compromise healing process, but yet at the same time, we're looking at proper, gradual, slow loading to the muscle. Because ultimately, hopefully by strengthening the muscles, then you can have a more active lifestyle. If you're talking about walking, talking about getting out of the bed, so these are actually key. So in terms of when to start exercises, it really depends on the spectrum of cancer journey. So as mentioned, somebody, say for example, like yourself or Joan, is a good comparison. So Ella, you're someone who have completed your cancer treatment for the longest time, and you're quite stable, you're not on any ongoing cancer treatment, for example. And for you, it's actually really trying to follow the American Association guideline in terms of loading the muscles. We're looking at 2 times per week. And of course, looking at 60 to 75% of the load that we're looking at. But that depends, provided you have no prior injury to any part of the body. So I think the key is always to engage a specialist, look at the current condition first, and they'll prescribe based on your needs. So that's one spectrum. And then the other spectrum is someone like Joan, for example, still undergoing chemotherapy, for example. So that's where we need to take into account of what are some of the side effects when you have this cancer treatment. And very common, it's fatigue. A lot of time, this fatigue is different from the muscular kind of related fatigue. So we need to draw a line on how much to push our body to condition versus the kind of side effect that you have from the chemotherapy. So for Joan's cases, I will always recommend to start gradual. Do something that you like. Say, for example, if you like to do walking, but instead of running, you do slow walking, you can still get to enjoy the environment, especially now that COVID has perhaps more settled. You can choose a time where there's lesser people that do not expose you to any sort of infection, for example. And you can still walk slowly for at least for the next 10 minutes. But that's more for a person that is undergoing cancer treatment. But how about loading? So for now, you do not have any open wound or open surgery, for example. So you can still gradually start your loading using those bands that you may have came across, or even those water bottles you have. But I think the key is more about safety, and at the same time, your fatigue level, say for example, 0 to 10, can be extremely fatigued. We're not looking at that, essentially. We're looking at just you feeling tired, 3 to 4, while you're doing exercise. So if next day you wake up and gets, more than that, then you have to retreat the exercise again or lowering down. So at the end of the day, we're not looking at completely not doing anything, because that's not very good, because any complete rest in bed, you're going to lose 10% of the muscle mass in a week. So we need to have a little fine line in between to make sure that our body still has some form of physical activity while you're undergoing chemotherapy. So that's why exercise is safe throughout the whole spectrum. We have to tweak the intensity accordingly to based on your current condition and the cancer treatment.
Thanks, Richard. So we have another question which has come in several parts, but I think I'll address the first part to Dr. Dean first. What do you do when you have a hernia, and what are the ways to prevent it from getting worse?
I presume the question is about peristomal hernia, is it? I have to assume so.
Yeah.
Okay, the strategies to manage a peristomal hernia is actually quite straightforward. Your surgeon should be able to tell you this. Number one, it doesn't mean that if you have a peristomal hernia, you need it fixed. Peristomal hernias will occur the longer you have lived with a stoma, as evidenced by you, Elil. It's just the way it is, because you have a defect through a muscle which was never meant to be there. So with time, that can actually enlarge, like I was showing you on the illustrations. Management involves modification of your stomal device or your stomal apparatus. So there are many available options that your enterostomal therapist or your support group should be able to advise to try to work around managing that, because ultimately the bottom line is the device has to fit without leaking. Even though you have a stoma, have a hernia, if your device can fit without leaking, leave it alone. Okay. The primary singular indication for us to surgically fix the peristomal hernia is when it reaches a point that there is no way to fit a device without it either peeling off or leaking around. So once you have that, and we have tried and exhausted all the options, then we'll have to sit down and really have a conversation to decide, okay, maybe we will have to surgically address this. Yeah.
Thanks. And there are three other parts to that question, and I'm going to try to attempt to answer a few, and the rest I think I need to advise that they seek help from their ET nurse or the product specialist. But the questions go like this. I'm now wearing a stoma garment. I believe they are referring to a support garment, but it had leakage. And I noticed that when wearing garments, the discharge stick to the output area. And this seems to cause the skin around the stoma to itch and even be painful. How do I cope with this situation? Do I change the base plate once there is a pain, even I just changed it after 8 hours? So basically what happens is, like Dr. Dean mentioned earlier, if you wear a support garment, then it will hamper the output from coming out of the stoma because it's pressing against the stoma. And it's natural that it presses against the back and there will be leakage. And for this, I think the product specialist from your appliance vendor or even your stoma nurse will be able to tell you how to deal with it. And I'll be very happy for the person who asks the questions to contact us after this webinar, through our website. And I can put you in touch with the people who can help you with this, because I think now there are some devices to actually prevent that. And yes, and if there is itch and pain around the stoma, right, I think you have to get it checked. So please see a stoma nurse first to find out what is the underlying cause, right, before we talk about solutions. All right, so different symptoms you need different interventions for different symptoms. right? So my advice is, number one, see an ET nurse, and number two, if you need help with this, please get in touch with us after this, and we'll make the necessary arrangements for you. And having said that, maybe Dr. Dean, you have anything to add to this?
Yeah, actually, if I can just quickly show this, I think it will help. So I think most patients will be referring to this peristomal skin complications. You'll see that it occurs in more than half of the patients. Like I mentioned, that's the commonest problem. And like you mentioned, Elil, it can be due to chemical, it can be due to mechanical, it can be infection, it can be allergy. So exactly, you need to consult your antrostomal therapist, ET nurse, to find out, because they will be able to tell you, because like, for example, this is mechanical, the other one is irritation. So you get two different things. And then sometimes it's so bad, we see patients where the skin is so bad that you see, if you don't solve the skin problem, you can't fit the bag, your device. It's as simple as that. Because so there are times where we even actually have to leave the pouch off and just really aggressively treat the skin. And usually the skin heals quite rapidly when you remove the stimulant or the irritation, the irritative component. And then we try to fit that. So I just want to share that the skin care and skin complications is very important, and it's critical part that your ET nurse will be able to help you. Okay.
Thanks, Dr. Koh. And I think there's another question maybe you can help us to address is avoiding leaks with an enterocutaneous fistula post-op bag.
Avoiding leaks with an enterocutaneous fistula. Okay. Enterocutaneous fistula is not a stoma per se. An enterocutaneous fistula is an abnormal connection between the small bowel and the skin. Okay, so most enterocutaneous fistulas need to be fixed. It's not a permanent thing. It's unlike a permanent colostomy or a temporary ileostomy or diverting ileostomy like what Joan has. An enterocutaneous fistula is a pathological problem that needs to be fixed. But in the meantime, what most patients will have is they have the device that fits over, similar to having a stoma. So I presume this came from a patient who has that. And how to manage enterocutaneous fistulas depends on where or which site of the intestine this fistula is arising from. So to put it simply, the further downstream the fistula is coming out from, that means the further down, the last part of the small intestine or the colon, those are best, easier to manage. If the fistula is coming from the upper part of the first part of the small intestines, it's more difficult because you have your bile, your pancreatic juices, and these are very corrosive. And these are the ones that cause a lot of skin issues. Now, enterocutaneous fistulas, unlike colostomies, there's no outpouching, it's just flush. So you can imagine the content is just seeping up and just filling. So it's an incredible challenge to manage that. So you really will need a huge support team and your surgeon to be on top of things to manage these. Yeah.
So thanks a lot for that, Dr. Koh. And with that, I think we've addressed all the questions that have come prior to this session and during this session. And so it leaves me now to thank all of you for joining us for this special patient summit. I hope you have enjoyed our conversation and learned from it. And on behalf of OAS and ConvaTec, we would like to thank Joan, Dr. Dean, and Hui Chen for joining us. And please don't hesitate to get in touch with any of us if you need support or further information. Your one-stop shop will be, of course, OAS. We have a website, and just go in there, and there's a hotline to call, and we can, put you in touch with the doctor as well as the physiotherapist if you need their help, right? So so thanks everyone for spending your precious time with us, and have a great weekend and stay safe. All right. Thank you.
Thank you.
Thank you.
Thanks.
See you, Ariel. Bye, John.
Thanks, doctor. See you.
Thank
See you, John.
Thanks.
Take care.
Bye-bye.
Oh, thanks, Fichan and
Bye.
Ariel. Thank you very much.